Hello, Rob Lejeune and Dr. Naren here, talking about reference dentures, digital reference dentures. If you've been living under a rock, you may not have heard of a digital reference denture. But if you spent any time in the 3D world, there is so much value with iOS scanning and using a reference denture technique to skip a lot of steps that unlock efficiency, reduce chair time, increase patient satisfaction, and getting to those finals results with a high degree of confidence as a clinician, and giving your patient excellent results. So, Dr. Naren, we're here today to talk about a reference denture case that you did, and the bottle of wine and the thank you card that you got at the end, because you took the patient from where they were to where they wanted to be in a pretty short amount of time. So I'd love to hear about this case and just talk about how you did it. And, so let's jump in.
Yeah, it's great. These are some of my favorite cases now. I learned dentures completely analog 20-something years ago now, 25 years ago, my gosh. And it's a tedious process. I think we can agree in the analog world to make a denture well. There's a lot of visits, there's a lot of steps. There's a lot of potential error that can be introduced at any time in the process. Even within the same clinician, if I tried to make the same denture twice, it would be a little different.
So this is a case that patient walks in on the left wearing a denture, she's unhappy, and then you are able to take her to that final result in how many visits?
This was 3 total visits within 14 days.
Amazing.
And the 14 days is not because we couldn't have done it faster. That was just the way the appointments worked out, for her schedule. But the story of this patient is a little more than just the pre-op and the final, and the fact that we did it, pretty quickly, or, more quickly than it would have been with an analog case. But this patient, if you see the pre-op photo on the left, had this existing complete upper denture for many years. Like, this was one of those patients that had the same denture for 20 years. She's probably in her late 50s, and she lost a lot of teeth, and so she's been wearing this same one, and it really kind of became part of her identity as far as the way that she looked and the way that she spoke. It's been repaired a bunch of times, and she went to her longtime dentist when it was finally time where she felt to replace it, and her dentist tried to make her a new denture, but basically changed everything about her teeth. And when he delivered the denture, she said, well, it doesn't look like me, you gave me horse teeth, said, and she was just really unhappy. And they had a very long doctor-patient relationship, and it actually ended over remaking this upper denture, which was unfortunate. And so she found us by referral, and, because we had some of these other techniques, in our tool belts, we were able to satisfy her wants and her desires, and we happen to actually do it pretty quickly. Those are two separate things in my mind.
Yeah, her teeth on the left, they look a little bit worn and flat, and maybe older, not as youthful, and I could see maybe she felt like they were a little bit square and blocky, and and the teeth on the right look just significantly better. Not a ton has been changed as far as the width go, but I noticed you added some sharpness to the cusps and a little more, asymmetry, and it looks super natural. I mean, those look like teeth. It doesn't look like a denture.
I think that's a great point. I think we should probably accentuate that, is that a digital denture can look like teeth instead of looking like a denture. And I think you hit the nail on the head as to one of the big whys of how you can make dentures better, is that in the past, in analog workflows, we had to work on pre-manufactured kind of cards of teeth with very specific proportions that you couldn't really change. You couldn't characterize anything beyond maybe changing incisal lengths, or maybe, adding in some rotations. But apart from that, they're basically stock shapes. And now you have the ability to kind of treat a denture like you would a crown and bridge case, where it can be infinitely customized to your liking or to the patient's liking.
Yeah, my personal opinion is I think the most beautiful cases completed are the ones that have slight asymmetry, because
Yep.
that is how God made teeth. You know, it's
Yep.
just really unusual that someone has natural teeth that are just perfectly symmetrical across
Yeah.
the arch. I mean, some people want that, and
Yeah.
that's fine if that's what the patient wants. But
Yeah.
if you really want teeth that don't look like a prosthetic, adding a little bit of slight and subtle, asymmetry can really do the trick. And this does not look like a denture, and I'm sure
Yeah.
that's what she wanted.
Yeah, and really what she wanted was she didn't want to look any different. She wanted the denture to feel like what she always had. She just wanted a new version of it. I said, well, how about, what if we were able to make your new teeth essentially identical to what you have, but make some small changes and improvements? Like I pointed out, the midline on her older denture was not exactly coincidence with the midline of her face. And I pointed out that the buccal corridors on the left and right side were, maybe not as built out as they could be. And we pointed out the wear on the teeth. I said, well, what if I could give you the flavor and essence of your existing teeth, but just make them slightly better? And she said, that sounds great. And then maybe now we can go through,
Yeah.
how we did that.
You're gonna walk us through start to finish
Yeah,
of how you utilized your TRIOS scanner, your digital workflow. You did take impressions on this case. We'll talk
I
about
did. Yeah.
why you did that. And impressions are still, pretty accurate. And by scanning those, you get the border mold and all that. So, all right. So
Yeah.
here's how she walked in. Talk us through this case.
So here's your worn upper denture the patient's been wearing for many, many years. She's missing a lot of teeth on the lower arch, but her main concerns is just, I don't like the upper denture being worn. She's not saying that she can't function. She's not saying that I need these teeth filled in on the lower arch. And we obviously went through all the different potential treatments that we could potentially offer her. But her treatment plan at this time is to really just change the upper denture, and we're leaving the rest of her mouth the way that it is. And so when we saw her, we said, okay, what records do we need to take to be able to duplicate this denture? And we'll go through what a reference denture is. A reference denture technique is basically utilizing the patient's existing denture, no matter how bad it is or how good it is, and you're going to use that existing denture as your custom tray and your wax rim. So if you're going to do this analog, like her previous dentist did, it would have been maybe an alginate impression on visit 1 to then create a stone cast, then make a custom impression tray. Visit 2, border molded custom impression. Visit 3 would be a wax rim. Maybe trying the old denture in and then trying the wax rim in, trying to, trim and kind of melt the wax to be similar to her original denture. Then it would be a wax try-in visit after that, maybe a second wax try-in, and then finally maybe 4 or 5 visits down the line, and several weeks or maybe even months, you would have a final denture. And so that was definitely something in the past that probably turned me off to liking doing dentures. I can do this now. I could potentially do this within the same week if I needed to, depending on the relationships with my labs and the time that I have. So this patient did come in on a Monday, and so I basically just took her upper denture and I just used it as a custom tray. I basically just took my border molded impression. There's a million ways to do this. You can do this whichever way that you're used to doing it. And we should say, why didn't I just take this denture out and scan the edentulous tissue? I absolutely could have done that. It takes a little bit more, I would say, operator skill to be able to get an intraoral scan, especially when it's edentulous. The upper arch is definitely easier than the lower arch, but being able to kind of reflect the tissue and make sure that it's not moving as you're scanning, that's really the trick. And I found in my own hands, sometimes I do it really well, sometimes I could do it better. But let's say I did that and I took a scan of the upper arch, then I still need to do something to get the rest of the records, to get the jaw relation record. So I would still be using this denture in some way, either 360 scanning it and then having to relate the intaglio of the 360 scan to the intraoral scan itself to basically get all these records on a computer screen with the right vertical, with the right border extensions, with the positions of the teeth. So I'm still going to need to do something, that is, let's call it an impression,
Yep.
to be able to relate all these records together. So if I just use this denture as the custom tray, this took less than 10 minutes. Then I pick it right up and I basically 360 scan it with my intraoral scanner. You start on the intaglio side and you basically work your way around until you have the whole thing scanned. So now I have that. Then I took
Well,
the
it's,
scanner and I scanned the lower arch the best that I could. And then on the bite screen, I basically just put the denture back into her mouth. I had her bite into her normal bite. And now I have the arches in occlusion. You're going to say something.
yeah, I was going to note that with the latest TRIOS software, you can now tell it I'm going to scan an impression or I'm going to scan an existing arch, and it knows if it's scanning an inverse of an object or not.
Exactly. Yeah, when we do a case like this, I should say if you're in the 3Shape world, you just click removable on the left side of your Unite software. It'll then open up these different workflows, and you're going to tell it, am I scanning the tissue directly? Am I scanning an impression like this one was? Or am I doing a copy denture where I'm just
Yep.
360 scanning the existing denture and I'm going to replicate it exactly?
Yeah.
And so this one, we basically tell it that we're taking a scan of an impression,
Perfect.
and that becomes the upper data arch. And we're getting our bite in a conventional way, just like if she had teeth, we're putting the scanner on the left and the right. We'll get these two bites. The lower arch, I'm scanning right in the mouth, as you can see. Really, what this allows me to do is then to be able to get into the software. We can show that really quickly. The
Yeah,
first
let's
part.
walk through that.
The
This
first
is
part of dental
important.
system, if you haven't seen what lab software looks like, it's pretty useful to just get a quick view of, what is the technician seeing when you send this off, over the internet and they open it up on their step. Well, the first steps of making any denture, doesn't matter what kind of lab software that you're using, is like there's these preparation steps that need to be done. The first step is to refine the scan. So when we're using an intraoral scanner and with 360 scanning something, that's a pretty complex operation that's happening. There's a lot of two-dimensional images that are getting stitched together. You have two sides of the surface, you have the border, you have how they connect, and invariably when that happens, there's like little errors that get made into it, and there's little kind of errors in the mesh that the software is seeing here. And so if you clicked on these and you were active in the software, you may say that it may tell you this is like an intersection, or this is a void, or this is like a flying island of data, or something like that. And in the digital world, the quality of that mesh is really important, because you can't produce an object that isn't, completely closed, or maybe there's some artifacts in there. You don't really see it on the surface because the software has these features to show you like the color and the texture. But if you can peel all this away, there's actually like small defects that you can't see that the system is picking up. And the better that you are at scanning, the less of these artifacts you are going to have. Like, let's say you were having a problem like closing the object and you're 360 scanning your denture, and there was a big hole in it, and you send it to your lab that way, and you're going to say, okay, I did the best I could, I'm going to send it to my lab and they're going to manage it. Well, when they get to this step, they may or may not be able to manage it. Like if there was a big hole in the scan, sometimes it's too big of a gap or an artifact for the software to actually refine. So if you see there's some refine options on the bottom, it says, remove scan artifacts, close holes, improve scan borders. Those are built-in tools that the software has to be able to kind of, clean up a scan that we're sending in. But there's a limit to what it can do. So if you send a scan that's just not sufficient, your lab technician's not going to be able to hit the next button, which is
Yeah.
the whole idea of this process is to be able to hit next until you get to the last icon up here, which is your actual output. So if there's any problems in between and the system is not hitting next, then you're kind of stuck in the water. And so the whole trick of this is to provide data that is good so that the lab technician, the designer, or if you're doing it yourself, I do these myself, so that I can actually get through the workflow and I don't have to call the patient back and go back to square one, because no one wants to do that. So the first step is to refine the scans, and so the software is going to automatically kind of fix this for us. And then, in every lab software, there's going to be an occlusal alignment. This is not the occlusal plane of the actual teeth, but what we're doing in these prepare steps is actually making a virtual stone cast that we're going to then build the denture on. The digital laboratory steps are analogous to every analog step. There's just, they've kind of recreated everything that we would do, in the analog world, but there's a digital version of it. And so this one is basically like beading and boxing. So if you remember, in the analog world, we would take our impression, we would apply some beading wax, maybe 3 millimeters beyond the peripheral roll is what I was taught when I was in school, and then we would pour this master cast. So that's really what we're doing here, but what we're doing here is we're just segmenting out the cast from the impression of the denture. And we're basically making this. And in the analog world, when you poured your stone and you separated your model, maybe there's like some little stone blebs, or maybe there's some little tiny artifacts, and you can kind of fudge those little areas. I'm not saying fudge in a bad way, but if there's like little artifacts, we used to take a Bard Parker blade and just kind of pop them off, and kind of, because you didn't want to produce the denture with those. And so then the software gives you an option to kind of sculpt those areas. If this was an immediate denture, this would be where I would digitally remove the teeth, instead of, having a burr. And I just found it really useful as a clinician to actually learn this, because now that I know this, I have a better idea on what I'm outsourcing to my laboratory. Then what ended up happening is I found it really convenient to actually have this all, under my roof, because I can treat these patients much quicker. And I'm still utilizing my lab. This doesn't cut my lab out in any way. It just makes it easier for me to work with them. And once you get experience, the whole process that I'm showing you here maybe took me 30 minutes of time.
So for the reference denture, you are in fact designing these yourself in Dental System?
Many times. I hesitate to say that I always do it, because I think when you have the tools, you do it when you need to do it and when you feel like doing it. You don't do it when you don't have time or you don't feel like it. And, it's really flexible that way. I think it's important, in all parts of dentistry, especially in digital dentistry, is not to be very dogmatic about, I have to do it this or I have to do it that way. I just love having the tools and a little bit of the knowledge. I'm certainly not as experienced as you guys are, but if I can get to at least the enthusiast level of knowledge, it really helps. It really helps me practice dentistry and treat patients, and so I think that there is, if I can give that kind of advice to a doctor getting started, it's that, if you're into this even a little bit, there's a for putting in a little bit of time and some investment to learning these little kind of pathways, I call them. So this is just the pathway for me to do a denture tooth setup and have something that I can print out for the patient. Which is we did this within 48 hours for this patient.
It's a tool in your toolbox that you're able to use when you want to, given the circumstances, the patient condition, their needs, their timeline, and I love it.
Exactly.
Let's keep going.
So this is basically, now we're setting the occlusal plane. So this is actually the occlusal plane that we're going to set for the digital setup of teeth that is going to come in the next screen. How do we figure out what size of teeth that we're going to use with a digital denture? In the analog world, I would have my Dentsply clear ruler that I would basically bend around the outer part of my wax rim, and on my wax rim I would basically carve in the canine distance, and I would carve in the midline, and I would carve in the high smile line. And in the digital world, we do it a little bit differently. Basically, it's just asking me to mark out the characteristic points. So I'm going to mark out where the canine point is, mark out where the incisive papilla is, mark out where the tuberosities are. And that's going to allow the software to actually propose teeth in the mold and shape that we choose in the right size, which I think is pretty neat. Now that we have this virtual digital stone model cast, if you will, in the virtual world, we're going to basically mark our denture boundary. And you can mark the denture boundary whichever way you were taught in school, whether it was to the height of the roll or a few millimeters past the peripheral part of the roll. You have the option to kind of click these points and edit these control points to define the border of your denture. And then you have the next step. If you do all these steps properly, you'll be able to click next up here and go to the next screen. And this is where we can work with blocking out any soft tissue undercuts, or we can change the path of insertion for the denture. And then we get to a point where we're actually going to set the teeth. And so we have the option to pick many different molds and shapes and teeth. And since we actually will also align a portrait photograph of the patient, we can actually set the teeth, in 3D space, according to the patient's face very, very easily. The idea is that we can basically get to a point that we have something that we can print out that we can show the patient. And if I just kind of go back to this, let's go forward a couple of steps. The end point of this, basically 30 minutes later, was that I had a denture that I could then enter into my 3D printer and print out. And so, this is the output of that. So I took her records on a Monday morning. I did this design when I had a little bit of time during the day. And so at the very next visit, so we're talking 48 hours later, this is the product of my work. So I put this in her mouth, and she says, yeah, this feels exactly like my denture. This is great. This doesn't feel like horse teeth. It's like, I'm really excited. And I take a picture. I say, see, we kind of kept the essence of your teeth. We didn't really change anything. We still kept it a little unique, a little asymmetric. We just rotated the whole thing so that your midline was in line. She saw that, and she says, oh yeah, like I see how that really looks better. And then we kind of looked at it from both sides, and this is just Denture A2 resin from my Form Labs, my old Form Labs actually. So this is not an expensive printer. I basically just printed it out. I painted it with glaze. There's no pink on this or anything like that. And what the really cool thing about this is, what I have to say is, when you're doing a denture try-in, like a wax try-in, in the analog workflow, first thing that happens clinically is we all know that that's made on a base plate off of the master cast. And that you kind of adapt the base plate over, and it's not going to have the fit or the function or the retention of the final denture. And one of the most common things is when you get to the wax try-in phase, you put the wax try-in, it falls right out of the mouth, and the denture says, oh my God, is my denture going to be like that? And you're immediately backpedaling. And no, well, this isn't the way it's really going to fit. We're just looking at the shape of the teeth. Here, let me go get some Fixodent. I'll put this in. Oh, am I going to need to use Fixodent on the new ones? Even when I would try to almost verbally prepare people that this is going to be loose, they almost can't help it, because when it goes in their mouth, they're concerned. It's just, oh my gosh, is this what it's going to be like? And we all know that it's not. But I'll tell you the truth, sometimes I would get to the end of a case and you get the final denture and it falls out because maybe my border molding wasn't good. Maybe we overextended somewhere, and that's stressful. Or maybe I didn't take a good impression. We have to go backwards a step. Then you've actually lost a lot of trust and capital with the patient, and now you're kind of backpedaling, you're trying to fix something. So what I love about doing these this way is that when I get to this step and I put this in the mouth, it's not a try-in, it's a prototype. It's exactly going to reflect what the final denture is going to feel like and fit like. So if I have 2 sore spots that I have to adjust on this prototype, that's the exact 2 sore spots that I'll need to have on the final. If I put this in and it just falls out for some reason, I'm not embarrassed because I already have the final. I'm just going to tell the patient, it's like, oh yeah, we need to kind of refit one error, and I have a chance to do another wash and maybe kind of fix some error that I made. And so I really love that about the digital prototypes.
Yeah, you're testing, suction and fit.
Yeah.
Really, the full function of the final denture is what you're testing in this prototype. It's everything the final is going to be as a prototype.
It's just not in the same type of material that the final is going to be like. And, and that's how we got to this endpoint, in a very short period of time. And that prototype in my practice now becomes a spare denture. So it's actually, a wax try-in is destroyed, as it's made into the final. It's a benefit now is I don't need that prototype. Now that patient immediately, with no extra cost or time on my end, has a spare denture.
This is amazing. You're 20 years of 3D dentistry culminating into a very simple workflow. Obviously, it does take some training and knowledge of scanning and design and the process you need to go through. So you're doing, treating these cases, these reference denture cases in much less time. Talk about your fees and how you've kind of approached that. And you mentioned you've been able to raise your fees a little bit, just given the time premium.
I think this is a great way to kind of think about how to fit digital dentistry into your practice, because in my experience lecturing on this for the last 8 or 9 years is that when I meet with dentists, a lot of dentists don't really like to do dentures.
Take a lot of time.
Yeah, they take too much time. They're not predictable. I can't get the insurance company to pay as much as I need. They're not profitable. And those are all real things that happen with the analog dentures. I found that once you can kind of digitize the process like this, well, what if you can make it really predictable? What if you can make it much faster? What if you can give the patient more benefit, like give them a better product? One way to think about it is that, hey, I can not only actually now provide the service, but I can justify maybe having a little bit of a premium to what my previous fee was. And it's sort of a win-win in that way, in my mind. This denture service that I gave her was so much better than what she got from her other provider. I think it is worth more because I did do it in less time. I did it exactly according to her wishes, and I did it efficiently. And I did it to the same level. It's the same strength. It's going to have the same, lifespan. It's probably even better because there's no way that a denture tooth can pop off this. It's a monolithic denture. It's very strong. There's no processed acrylic. I think it's a better product. So you can actually say, hey, if you wanted to find a way to maybe get compensated more for a case, well, you need to provide more value to your patient. It's not just about charging more. It's like, why are you charging more? What is the patient getting? In this case, the patient's getting a lot more. She's getting exactly what she asked for, and she gets to have it really quickly. The
prototype denture becomes an emergency backup denture as well.
We're literally building in value. And if you're in a practice where, maybe you're controlled by managed care and you can only charge or get compensated, X dollars to do a denture, and you feel like it's not enough, or you feel like it's not profitable or even worth your time to offer it, well, how about if you can make it more predictable, and you could make it faster, and you could make it better? You can make a case there that now, even within the confines of whatever practice situation you have, this now becomes a viable service to help patients. It's not a loss anymore. It just becomes makes removable so enjoyable, and I can't stress that enough, that anybody can do this.
I've heard this over and over from many clinicians when they get into this digital workflow with reference dentures. It actually makes this type of case fun, because when the patient walks in, as long as a denture is just decently fitting, right? It's close. Even if the teeth are bombed out, you basically got a custom impression tray to start with. You're going to have a good bite. Even if you want to open the bite a little bit, that's not too difficult. And you can get to a prototype that's going to 90+% of the time fit really, really well. Maybe a few adjustments. So
hated about the old way is that you would do a wax setup and you'd put it in and everything was wrong. And now you have a Bunsen burner. You're trying to move the teeth while the patient's there. And now there's wax everywhere. There's wax on the teeth. And it's just so messy. It's so messy and inaccurate. And it's just, literally have an open flame that's in your office. It's just, if you can make an analogy for the most backwards thing, is that I've now created a fire in my operatory in order to provide this service, and that's like normalized to us. So like, well, of course you need a burner, you need a flame. And what other medical procedure would that be okay? Like what, you walk into your cardiologist's office and they're lighting a fire in the room.
It is comical that you point that out, for sure. Well, Dr. Naren, thank you for sharing your time and your wisdom with us. For
Thank
those of
you.
you watching, Dr. Naren's available at rebel3d.com/Naren. He's available to help in your 3D digital journey with iOS scanning, dentures, implants, a mix of a variety of cases, digital workflows from the simple to the most complex. Thank you for sharing your time with us today.
Thank you. Yeah, I see my job is helping the next person's learning curve not be quite as steep and painful as mine was, so
Well, I love that. Plenty to
thank
learn
you.
from you. Thank you.
Thank you. Thanks, Rob.